Friends, welcome to today's session, Young India Intensivist webinars. And today the topic is discussion on different cases or case in critical care medicine series. And today it will be presented by Dr. Nikhilesh Jain sir. Sir is Director and Head of the Critical Care Department and Operations at CML Hospital, Indore. And moderating it will be Dr. Abdul Ansari sir. Ansari sir has been there on our programs many times, and we thank him for his contribution to the teaching. Sir is director at Nanavati Hospital of the Critical Care Department. So thank you, sir, for your continuing contribution to our teaching. And
thank you, Tabesh. And I think I must say that you are doing a wonderful service to the whole student community in intensive care. This is very important. And I think all of us are more than happy to be a part of it. My apologies, I am in transit, but give me 5 to 10 minutes, I will get a better stable connection. But I'm a part of it. Thank you. Please proceed.
So thank you, sir, for the encouraging words, and I'm sure all the teaching that you've done so far has contributed to a great extent to for all our students as a support. Then we have Dr. Kishore Mangal, sir. Dr. Kishore Mangal, sir, is a consultant in Eternal Hospital, Jaipur. Sir has been on programs earlier also, and he had taken a session on weaning trials and weaning. And then we have Dr. SIDDARTH Goswami, sir, is a consultant in Apollo Hospitals, Guwahati. And sir has again been there in our programs earlier and has contributed to the program. So we thank everybody, and we especially thank Dr. Nikhilesh sir for making the presentation. And with that, I think I'll hand it over to Dr. Nikhilesh sir to join to start the proceedings.
Thank you so much, sir. Over the course of about next, probably the cases would get over within next 20 to 25 minutes. But the amount of discussion that is expected to be generated out of it may take longer than our scheduled time itself. At least that's what I feel. And I'll just share my screen. Right. So this is fine. This can be seen.
Yes, yes. Just make it full screen.
Yeah.
You have to go full screen. It is not going full screen.
It is made. It has been made full screen.
This is full screen now, sir.
Okay.
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 Okay. So now I'm not disclosing the diagnosis at the outset as it is. There's a common thread that runs between a few of these cases, and the discussion would focus on that only. Something that we see very commonly, but few atypical presentations that we came across over the course of last 8 to 10 months. So without much ado, I'm launching straight away into the case. This is about an 18-year-old female. She had irregular cycles along with amenorrhea from past 2.5 months. She was referred to us from elsewhere, and she actually presented in another hospital, which was a peripheral hospital, with recurrent vomiting and convulsions, and swelling was noted over right lower limb. Now, they could not make head or tail of it. They actually referred the case to us. And because she was in altered sensorium, she was irritable, she was referred to us as a case of meningoencephalitis. So we did an examination at baseline, and she was protecting her airway. She was irritable. She had altered sensorium, but her hemodynamics were stable, and she had a sinus tachycardia on ECG. There was no neck rigidity or focal deficits that were noted. So per se, it seemed like it was referred to us as a case of meningoencephalitis coming from outside, convulsions, vomiting, and we never suspected anything else here. So what happened was, we went ahead and did an initial workup.
So we just go back to Dr. Nikhilesh. We just see what is happening there. So here, she's having recurrent vomitings and convulsions. She is 18 years old and irregular cycles. So as far as irregular cycles with amenorrhea is concerned, it is probably a gynecological disorder, though it will be worthwhile to rule out pregnancy, and it has to be ruled out, which I think you must have ruled out.
Yes, so, absolutely. We did. It will feature in the workup.
Yes. So for a patient presenting with vomitings and convulsions, 18-year-old, what possibilities would you think of, Dr. Kishore or Dr. SIDDARTH? You'd like to answer that, please?
Yes, sir. The first thing definitely will come into mind because the patient is in amenorrhea, so pregnancy has to be ruled out. And pregnancy, if it is positive, then you have to rule out the other complications like PIH and all. Then, other than that, since the patient is having convulsions and vomitings, and so there could be reasons where the patient is having raised ICT, and it can be because of any space occupying lesion. This would be the second differential diagnosis which will come immediately into the mind. And these will be the two main differential diagnoses to start with.
Okay. So, Dr. Siddharth, any other differential for vomiting and seizures in this patient?
Sir, I agree, sir, with the history of amenorrhea. The first thing which comes to mind is amenorrhea and convulsions is eclampsia, PIH. That is the first thing. And second is raised ICP. I would think corticovenous thrombosis, CVT, will be a strong possibility in this scenario.
So why do you think
That is
you
another.
would have cerebral venous thrombosis? Any particular reason?
Sir, with the history of amenorrhea, pregnancy, with a history of vomiting,
No, we are not sure.
dehydration.
We are not sure about
No.
pregnancy. There is irregular
No,
cycles.
we are not sure. If the patient is pregnant.
Okay, okay. So, as far as the causes of convulsions are concerned here in an 18-year-old female, first of all, amenorrhea has to be taken with a pinch of salt. There are irregular cycles going on.
Yeah.
We do not know whether this is a gynecological disorder or pregnancy. So,
Right.
you would just leave that apart and consider the differentials for vomiting and seizures in an 18-year-old female. It would probably point out towards the swelling also. You have to consider there is right lower limb swelling, and that has to be taken into consideration. So you can have simultaneous DVT in the brain and in the thrombosis in the leg and thrombosis in the brain, and that is one possibility. Second possibility is there could be cellulitis in the right lower limb with meningitis in the brain. Then there can also be a tumorous swelling of the lower limb and tumor in the brain. So there could be cancer. Sometimes bony cancers can present this way. Then another possibility would be a DVT with paradoxical embolism. So paradoxical embolism occurs in PFOs, and what happens is that in PFOs there's a paradoxical embolism because there's a right to left shunt. So from the lower leg it comes to the IVC to the RA and goes to the left side of the heart, and from there it goes to the brain. And then you have possibility of metabolic encephalopathy with DVT. So these are some of the possibilities. Another possibility, considering the fact that she's a young girl, SLE would be a possibility with predisposition to thrombosis in the brain and in the legs, like a Apla syndrome or secondary Apla syndrome or a primary Apla syndrome is a possibility here. So these are some of the possibilities, I think, and with the differential, this differential in the background, I think we shall go ahead now. So Niklesh sir, please go ahead.
Right, sir. So we did a workup. She actually showed up a sinus tachycardia, simple sinus tachycardia on electrocardiogram. We did a brain imaging, and that incidentally was suggestive of deep cerebral venous sinus thrombosis. Superficial as well as the deep, both were involved. And she had a Doppler which was consistent with DVT of the right lower limb. She had an echo which was suggestive of RA-RV dysfunction. So because of all these findings, we did a CT pulmonary angiogram, and it was consistent with pulmonary thromboembolism. We did a urine pregnancy test, which was negative with a non-contributory ultrasound of the abdomen. So any thoughts on this, sir?
So we shall go back, we shall now just try to analyze this. There is simultaneous thrombosis of the cerebral venous sinuses, and there is a DVT. So the thing is, we have to see the stability of the patient. First of all, CTPA, we have demonstrated pulmonary thromboembolism and eco-suggestive of RA-RV dysfunction. So here the hemodynamics would be very important. First of all, you have to manage the patient, and then you have to look at the cause. There is a thrombosis in two different sites, unlinked sites, and there is a venous thrombosis, right? So you can get sometimes venous thrombosis in pregnancy, but there is no pregnancy. One of the predisposing factors for cerebral venous thrombosis is pregnancy, but like you have shown, there is a negative test for pregnancy. So
Correct.
we would like to know what is the blood pressure, because the question here is whether we should thrombolize her or not thrombolize her. That is the most important thing.
Her BP even at baseline was around 100/70, and it did not change much. She had a good pouring urine output, and we did not feel the need right now of thrombolizing her as an emergency. So that was the thought process that was going on initially.
Okay. So
I would like to jump in here, Dr. Ansari. Sorry.
yes, yes,
There are two
Yes, sir,
things.
absolutely. You're welcome.
sir.
No,
You have, please.
am I audible?
Yes, yes, sir. Yes, sir.
So two things. Whenever we talk about what is called concurrent thrombosis, as Dr. Tapesh also said, at two unlinked sites, the hypercoagulable workup comes very high on the card, obviously. And of them, as in fact, lupus cerebritis with SLE and predisposing with some kind of a intercurrent illness, dehydration, precipitating thrombosis could be one, with contraceptive usage or other hormonal usage can also kind of add on to the fire. So this seems to be a kind of very interesting scenario where multiple thrombotic sites can be there. But most importantly, I think catastrophic APLA should be kept in mind at this point of time. Number two, when we talk about the focusing of the bigger lesion, which is always pulmonary embolism, because that can be really sinister, can immediately worsen the outcome because of hemodynamic instability. The sequential assessment for hemodynamic impact by some kind of organized scoring by pulmonary embolism severity index or something would be warranted at this point of time. Over to all of you.
So the blood pressure is 100/70, right? And there is tachycardia.
So actually, she came to us with that BP, and she didn't drop her BP. All this
But
workup
there
took
is-
around 12 hours.
Yeah.
And because she was pouring good amount of urine, our assumption was that this type of perfusion is good enough for her. So that's why we were in two minds. We had sent a procoagulant screen, but again, procoagulant screen, full procoagulant screen takes some time to come back for us. So, I mean, management-wise, that hardly would have made a difference for us.
Yeah,
It's just a matter
agree,
of
Dr.
documenting
Nicholas.
a diagnosis.
Yeah, so I think from my side, I would like to say here is that this patient is probably in an intermediate risk of pulmonary embolism, and since her hemodynamics are acceptable enough, we have to go with the intermediate, and echo is suggestive of RA-RV dysfunctions,
Correct.
and that gives us a high risk, the higher risk of intermediate pulmonary embolism. And in that case, you have to be very closely watching the hemodynamics and the respiratory dysfunctions and the pressures which we are seeing on the echo. If there is deterioration in that, then only we go for the high risk situation. Otherwise, we can manage it as an intermediate risk patient.
So if there is RA-RV dysfunction, would you like to thrombolize sometimes, because this is classified as submassive pulmonary embolism? You know, with the normal hemodynamics, and RA-RV dysfunction is a soft indication to thrombolize, because just to give you a bird's eye view, this is known as submassive embolism, and the indications for thrombolysis are what? One is clear cut, there is hypotension, that is one clear indication. Then the soft indications are submassive embolism, which is characterized by a normal BP but RA-RV dysfunction, especially RV dysfunction, which they have. The other indications for thrombolysis are, these are the soft indications, are if there is a patient is severely hypoxemic and the blood pressure is maintained. That is another indication, because he has thrombolized, has had embolism on a previous lung disease. Another indication is that tumor burden is extensive in the lower limbs itself, because that leads to a post thrombosis leg which has a lot of edema and dysfunction. So that is another indication. The other indication is if you see a RV clot, that is another indication. So these are some of the indications, soft indications, plus minus indications besides hypotension. So the only clear-cut indication to thrombolize a patient is hypotension. When you have hypotension, if you do the echo, you will always get RV hypokinesia. RV dysfunction will always be noted. You cannot have hypotension due to pulmonary embolism and a normal RV. you may get a normal RV with other kinds of thromboembolism when it is not too much, and that is possible. When the extent of thromboembolism is not that much, then you can get a normal RV and RA echo. But in the setting of hypotension, you will get a dysfunctional RV always. So that was about the indications and the role of echo. And anything else, Dr. Siddharth, you want to say anything?
No, sir. I think, sir, you have covered the whole topic very nicely, sir.
Okay, okay. So, Dr.
One more. Yeah, one more thing, Dr. Tapesh. I think very nicely summarized that when you have intermediate kind of a severity, the risk benefit of bleeding versus the possibility of chronic thromboembolic pulmonary hypertension, post-phlebitic syndrome, and clinical worsening, they all have to keep in mind. But the latest guidelines which has been reviewed had shown that even though there could be a high likelihood that the patient may worsen in the intermediate group, still the thrombolysis should be reserved for hypertensive people, because that occasional risk of bleeding definitely doesn't warrant that. But classically, if you are very worried, look at signs of RV microinfarction. So if you have a TROP-T which is very high, a pro-BNP which is very high, and there is a reverse Bernheim effect on the echo, those would be the only conditions where you can walk very, very gingerly on a thin, slippery slope of thrombolizing before hypotension. But for all the listeners, invariably, you will have to be prepared for a justification in case there is a bleed when there is no overt hypotension. Yes, shock index is one other way where you can justify thrombolizing even when the BP is okay. For example, at a blood pressure of 90, if you have a heart rate of 124, that definitely points the shock index towards a manifest shock. You can always argue that 100 heart rate and 140 heart rate can also be a occult shock. But most of the time, it is safer to watch closely and discuss with the family about the possibilities of early usage of, I would say, preemptive thrombolysis.
So we did actually, and what had happened was that when we discussed with the family, this was a family in whom we had to counsel them a lot, and there was a lot of a problem in the sense that you suddenly find that your 18, like the family was shocked, 18-year-old daughter suddenly developing all this within 2 to 3 days and coming to us and with no other major contributory history. They were simply referred from a hospital saying that she is very sick and she needs a bigger hospital. And just imagine their surprise when we tell them that there's a clot in the brain, there's a clot in the lung, there's a clot in the leg, and we need to do something major. We need to give a drug which can actually give rise to bleeding as well. And there is a soft indication, I believe, which sir quoted. It comes, American Society of Hematology has put forward for thrombolizing 2021, in which they have given certain soft indications for thrombolizing. So we had gone through that, and we were thinking whether we should go ahead with that or not. So I'll go on to my next slide.
So just a couple of words about the cerebral venous thrombosis. It has presented with headaches and seizures. So
Yes,
it causes increased intracranial tension, and on imaging CT or MRI, you get venous infarcts with this. That's how you pick it up. And these infarcts can be hemorrhagic, and they are in atypical locations. That is a clue. Sometimes in initial imaging, the thrombosis may not be evident, and you will get infarcts in atypical locations, and then you have to do a contrast, actually, MR venogram or a CT venogram to pick it up, actually. So that is, right. So I don't know how you picked it up, actually, the cerebral venous thrombosis.
We actually did a MR veno.
Yeah, so that is what you have to do actually to pick it up. If they can suggestions of atypical locations of venous infarcts or something in the initial imaging to suggest, and then you have to do a venogram to actually delineate it.
Basically, she had no focal neurologic deficit, and she had come to us with seizures. So initial thought was whether she is in post-ictal and we need to rule out the cause of seizures. So that's why MRI was preferred initially. And she had stable hemodynamics, so we had no qualms about moving her to MRI. So fine. Shall I go forward, sir?
Yes.
So let's look at this. These are certain helpful images. And this is what we saw actually. This on the left-hand side, if you view it from my perspective, it is the CT images, and this is the echo loop. Yeah, it's very classical.
Yeah.
So
You can show that whatever you want to show. Yeah.
So what we did next was, because there was no consensus on thrombolysis, and we had a neurologist also coming in. So she was started on low molecular weight heparin in therapeutic doses. She was given mannitol, an anticonvulsant in the form of levetiracetam and other supportive therapy. He sort of gradually improved in her sensorium. Tachycardia and lower limb swelling resolved gradually. And when she improved, she actually gave the history of having received progesterone-based hormonal pills to induce breakthrough bleeding. If you remember the history, she had amenorrhea from 2.5 months. And what really happens is, most of the time, the oral contraceptive pills that are used, most of the times they are a combination of estrogen and progesterone if they are meant to regulate the cycles. But to induce breakthrough bleeding, they mainly use progesterone-based hormonal pills. And progesterone-based hormonal pills to cause such widespread thrombotic manifestations is not a very common thing. With the mixture of hormone, with estrogen plus progesterone, yes. But with progesterone, it is not considered to be so common, even though now there are documented case reports for that as well. She got shifted to ward. She was discharged with a GCS of 15/15, and she remained stable on a 3-month follow-up. And like what happened was, if it would have been a CVT, venous sinus thrombosis alone, probably we would have left it at a 3-month follow-up on anticoagulation itself. But because there was a concurrent DVT and PE, we have decided to give it to her for a total of 6 months. She remains on follow-up. So any thoughts on this now?
Actually, like you have said, it is the estrogen component which leads to the hypercoagulable state rather than the progesterone. But it is important to send the complete thrombophilia profile. I think you must have sent it. Did you get anything on that?
No, we didn't get anything on that. We sent connective tissue markers as well as thrombophilia profile on that, but nothing turned up positive.
It's slightly unusual. Sometimes the tests have to be reviewed and all, but maybe the oral contraceptives were contributing to the thrombosis. It's possible. We cannot rule it out altogether. They are a known cause, and she was on oral.
We were surprised. I mean, to induce breakthrough bleeding, it seems a lot of a gynecologist has also seen the patient. So for her, it was the first time like she had ever seen a progesterone-induced PE. But I would like to know your thoughts on that.
I think is mainly the estrogen component, but with what is said is oral contraceptives with estrogen component contributing to the bleeding, but progesterone is also known to cause. It is not that progesterone does not cause. For example, there is a tablet called medroxyprogesterone we use for stimulating breathing. The side effects of that is venous thrombosis. Medroxyprogesterone. It comes by the name Medral. That is supposed to increase in hypoventilating patients, to give it to increase stimulate the breathing, and side effects of that is venous thrombosis. So progesterone also contributes, though classically estrogen is the one which causes the thrombosis much more than progesterone. So I think with that we'll move on to the next case.
So we go on to the next case, right? This was a 40-year-old female, extensive knee joint arthritis on a background of rheumatoid arthritis with ongoing DMARDs. And she was subjected to bilateral TKR. She was mobilized on day two post-op in wards. As her menses had started a day back, immediate post-op, the anesthetist, this patient was in ward. She was not in ICU primarily. And the anesthetist considered to add rivaroxaban after 24 hours as she was having a heavy flow. Soon afterwards, her BP dropped. She started complaining of uneasiness along with air hunger and tachycardia. So, pretty straightforward.
Yeah. Well, so Dr. SIDDARTH, what differential would you like to consider for the drop in blood pressure in this patient who's post TKR day 2 and suddenly the blood pressure drops?
So the first thing which comes in the mind, in any post-operative patient, is whether there has been a bleeding somewhere.
Yes. Any other differential? So that she could be bleeding and having hemorrhagic shock. Anything else? So there are other differentials also. Dr. Kishore, you would like to add any other differential?
Yes, sir. So this patient is a post-operative patient. So definitely pulmonary embolism will be kept in a differential diagnosis. The first differential diagnosis will be hemorrhagic shock. The second will be pulmonary embolism, and there could be some anesthesia related complication, but post of day 2, I don't think so that would be a major thing, and hypovolemia is also usually not there. But so the main differential diagnosis will remain hemorrhagic and the pulmonary embolism.
Yes, yes. And apart from that, just to add to that, like you said, it is day 2, but on day 1, anaphylactic shock sometimes occurs in the OT also due to neuromuscular blockers. We have seen 1 or 2 cases. The patient is coming out of the OT. You have to think of anaphylactic shock. And day 2, you can get myocardial infarction also. The incidence of MI in
Post-MI
patients, post-surgical patients is increased. Myocardial infarction, but she's 40-year-old female.
Yes.
No risk factor, so it will be unlikely. But definitely, when hypotension occurs in the first 48 hours, do consider myocardial infarction in the post-surgical patients. And I do not know whether she was on epidural analgesia here. If she was getting epidural analgesia, that could contribute to.
She was not on an epidural analgesic.
Okay, so I think these are the differential diagnoses, and sometimes she's on anticoagulants. Cardiac tamponade can also occur. You can get anticoagulant induced pericardial effusion, which is hemorrhagic, and cardiac tamponade, which can lead to bleeding. So these are some of the.
She was not initiated on anticoagulants. Actually, it was planned that we usually start off on rivaroxaban for our TKR patients as a protocol after 6 to 10 hours. But what really happened with this particular patient was that she happened to have her menses, onset of menses, after she had got operated. So anesthetist thought that we can delay the introduction of the tablet as she has been mobilized for another 24 hours.
Okay. That is okay. I thought she was on rivaroxaban already, but having flow, menstrual flow is not a contraindication to starting prophylactic kind of anticoagulation. I think that is not a contraindication, but it is a subjective thing. Sometimes you do not realize what that you may come up with something like this, but that is what the differential is for the hypertension. Dr. Ansari sir, any comments? So I think Dr. Ansari sir is knocked out for the time being. You carry on.
So she got shifted to ICU. When she got shifted to ICU, she was received in a state of shock. Pressors were initiated. ABG was suggestive of typical hypoxemia, type 1 respiratory failure. She desaturated on us. She had a seizure. She was intubated electively and was taken on invasive hemodynamic monitoring. Within half an hour, she was on very stiff pressor support, and she had a heart rate of 100 to 110 beats per minute. In the ABGs, her hemoglobin were fine. Yeah, I mean, it was pre-op, it was around 11, and now it was around 10.5, 10.6, something like that. So we did not suspect a hypovolemic shock or a blood loss here.
So,
any thoughts?
So means there were no parameters to suggest anything else. So the hemoglobin didn't drop, but the hemoglobin may not always drop dramatically. It takes 48 hours, and there was no evidence for anything else. So you thought she had pulmonary embolism, huh?
That is true.
You need to do an echo immediately.
Okay. So you did the echo.
Okay, so we were fairly sure by now that probably she had a EP only. So we went ahead and did an echo. So this is the echo loop. Again, I picked up the most classical echo loop out of that.
Yeah, so this is again a classical PE.
Yeah. And I mean, now
the RV is dilated and the septum has straightened. So that is a classical sign that there is a severe RV dysfunction is there.
Correct. So what happened next? She arrested on us. Before, like, we could do anything major, and we did a rapid counseling of the patient, and within 10 minutes, we actually thrombolized this patient with tenecteplase with an ongoing CPR and an invasive ventilatory support. Now, post thrombolysis, her RV functions actually improved dramatically, and for some time, she held on to her pressures. However, she had multiple episodes of asystoles following that, and she succumbed. Despite supporting, she succumbed after sort of 12 hours of shifting to ICU. We had actually offered them ECMO, VA, but the family wasn't ready for that in such a short span of time. So we had to let go of that option. Any thoughts?
No, only one. So is there any contraindication for thrombolysis, Dr. Mangal here? Should this patient be thrombolized?
I think there's a lag in the video.
Dr. Ansari sir, are you there?
Yeah, hi. So,
Sir,
I
your
can
comments on thrombolysis and contraindications and what is the best thing to be done here, if you can just join in again.
I missed out something in between, but as far as I understand, 40-year-old lady who had undergone the surgery, not yet started on DVT prophylaxis, and she has this sudden crash event.
Yes, yes.
So, I think,
she has pulmonary embolism, she has arrested and they have thrombolized her. So
but
now,
the pulmonary embolism was documented, right?
yes, sir, in the same
No, sir, we couldn't get a CT done for her. She was like she arrested before we could plan a CT. It just happened within half an hour, 35 minutes. And she had come to us from ward. We couldn't get a CT done. And
So Dr.
we were just
Niklesh,
able to get an echo done. Echo was suggestive of severe RA-RV dysfunction, and she had hypotension, pressure supports were high. We discussed with the relatives and we told them that this is the possibility, and the only way that probably we could tackle this sort of emergency would be to thrombolize her.
I agree. So I personally feel if there is a no closed cavity and the risk of bleeding, which is still there because of the, it was a TKR, you said?
Yeah, it was a bilateral TKR.
So though there is a risk of bleeding very high for both the legs and could be so bad that the implants may actually get kind of affected. But because of the catastrophic nature of the bleed, if you go through the Indian Journal of Critical Care, in the Indian Journal, we had published one Indian consensus PE guideline looking into this specific need, that what if there is a person who is unable to be shifted for any definitive imaging, and the only imaging that you have is a 2D echo at the bedside of a hemodynamically unstable patient, there is definitely no absolute contraindication for thrombolysis. In fact, there is a relative or conditional indication for thrombolysis, and I would have preferred to do that for a young lady, specifically after discussing with the family that we are justified in doing it. There is no other explainable cause for
We
this.
took a consent. We took a consent from them for that.
Yes, and
But,
thrombolysis should be done.
Dr. Ansari sir, but as you will agree that there is a contraindication to, one of the contraindications to thrombolysis is a post-surgical state up to 2 to 3 weeks. So here, you know,
I agree.
if we use a thrombolytic agent, we are in a difficult situation because this happens sometimes, whether we should actually be trying and doing a pulmonary thrombectomy in this patient or whether we should go ahead with thrombolysis. Because, you know, if we start...
Catheter, catheter directed thrombectomy, as you say, is as contraindicated even post-surgically. So the whole concept that people think that catheter-directed thrombosuction has to be again associated with regional local thrombolysis. Yes, the thrombolytic burden comes down from 100 milligram to maybe 20 milligram. But sometimes even that amount is as likely because of the poor thrombin specificity of causing bleeding from the surgical site. So we are assuming that even in the worst case scenario, we may have to redo the whole surgical process. It's a closed cavity in both the knee, and that may not be really life-threatening and can be managed even if it is required to open it up. So the risk-benefit analysis has to be done. I think definitely there is no absolute contraindication at this point of time for a life-threatening PE, but all the listeners must know that at this point of time, they must take the family into discussion, get a cardiologist, the surgical team come into it, and see to it that a consensus is reached. But I would be pro-thrombolysis, and if there is an aggressive cardiologist or an interventional radiologist who would be happy to do a CDT, catheter-directed thrombolysis, that would definitely take a priority. So if it can be safely done, no doubt that is the better option.
So we tried that, but the problem was that the patient was having an ongoing CPR. So,
Correct.
I couldn't think of anything else to do in such a thing.
So ECMO, as you rightly said, was the correct option at this point of time. It's like an extended eCPR. You put them on ECMO, you give some anticoagulation there, and just stabilize the cardiac system. And majority of the time, these soft thrombus start opening up, and you start getting a channel into the pulmonary artery, and they get it's very reassuring. These people can, even after 2 weeks, can come off without needing any kind of long-term RV or LV supports.
I think, Dr. Niklesh, this patient in particular really didn't give you any time. Had she not arrested, then probably you'd have got some some time to
I would have saved her.
take
I would have saved her. For
exactly.
a 40-year-old female to lose her life because of pulmonary embolism is unacceptable.
Exactly. She just didn't give you enough time.
But this again comes back to the most important fact, as you all of us are probably working in NABH certified institutions. You notice that there is a new standard which has been added for the NABH in the
Correct.
last.
This was there in JCIA before. Now they've added it in NABH as well.
Correct. So if we go back, what was the reason for not starting a DVT prophylaxis here?
Oh, she started her periods right on the day post-op, and the anesthetist felt that because she was having a lot of flow, it's maybe better to start, and she was mobilized. So the anesthetist felt that maybe we can, sort of give that tablet on day 2, give her a gap of around 24 hours.
This again emphasizes and underlines the importance of discounting the regular menstrual periods to come in between for starting a DVT prophylaxis. I think we all have to underline again and again that 12 hours post surgery is the time where, if the surgeon is comfortable about the surgical point, initiation of some kind of a prophylaxis is mandatory for these high-risk patients. I understand mobility does give you some kind of pseudo confidence, but those people who are not really mobile because of their knee problem, they, by virtue of their immobility, relative immobility, are anyways more likely to land up with the DVT. So I think that's a learning message, very important learning message for preventable cause of death. In fact, DVT and pulmonary embolism is supposed to be the most important preventable hospital deaths.
And actually, the highest incidence is seen after neurosurgery and orthopedic surgery. The highest incidence of thromboembolism is seen after spinal surgery and orthopedic surgery and neurosurgery. And like we discussed earlier, menstrual flow is not a contraindication to starting prophylactic anticoagulation. Anyway, so I think we shall move on now, Niklesh.
Yes, I will. So this is case 3, and let me tell you that this is just a coincidence that out of the 4 cases I took, 3 of them are women. So basically, 28-year-old female, second pregnancy, delivered successfully by LSCS a day before. No prior history of venous thromboembolism here. There were no medical risk factors prior to this episode. Apparently, she was hale and hearty, very healthy. She had a very uneventful intra-op and immediate post-op duration. There was some, again, the catch line that happened, there was some oozing from the surgical side, and they thought that maybe we could defer the DVT prophylaxis to more than 12 hours. So what happened next was the rapid response team actually got a call for unexplained tachycardia, some amount of hypotension and uneasiness for a post-delivery patient. She became unresponsive. Code blue was paged, following which the team went and shifted her to ICU on invasive ventilatory support with an ongoing CPR. And again, in our opinion, we were thinking that it is again probably a PE only. Any thoughts?
So can we just the next slide, last slide?
Okay, I will go back to the last slide. Yeah.
So apart from the patient is having what a second pregnancy, and then there is postpartum. There is next slide, please. There's housing and DVT prophylaxis is again deferred, and then she has certain hypotension and tachycardia. So the priority here again would be pulmonary embolism. But what else can embolize besides blood clots? So just a question to Dr. Kishore Mangal, what else can embolize, especially in this patient?
Yeah, so amniotic fluid embolism can be there.
Yes, yes. And what else? What other kinds of embolism do we have?
Yeah, we have fat embolism syndrome. So this is probably not in this patient, but yes, fat embolism and amniotic, and then the air embolisms can also occur in the lines and all. And these are the common embolisms which we see, but the clot and the embolism remains, the thromboembolism remains the major cause. And the patient who is having such severe this unexplained tachycardia, hypotension, and becoming unresponsive in cold blue, pulmonary embolism will definitely from the first differential diagnosis here.
You will have to consider amniotic fluid embolism also in this?
Yeah, post-op patient, the first differential diagnosis will come as a hemorrhagic patient because this had a ooze, maybe there may be some underlying bleeding. So hemorrhagic shock, the pulmonary embolism, and then the third is MI. These are the three major differential diagnoses.
Sir,
at
our
this moment.
ABGs showed normal hemoglobin. Like again, pre-op and post-op comparisons, it was all good. So the most common cause that we suspect is usually hemoglobin drop of a sudden nature, but that was not there.
So basically, again, there is shock and hypotension as before, and the differential is more or less the same. But the thing is, age is what is the age of this patient?
She's 28.
28 years.
28 MI is unlikely, and there is
Yeah, unlikely, but yeah, if we talk about the differential diagnosis, it will be in the differential diagnosis list. So it's about
yes. So amniotic fluid embolism occurs up to how many hours after delivery? And when
yeah,
to hypotension? Dr. Niklesh?
We were not thinking of amniotic fluid embolism for her, to be very frank. She was apparently fine, normal, and to have amniotic fluid embolism as a sudden onset, this thing would have been, slightly difficult for us to fathom. I do not know whether can it present suddenly.
Yes,
Post-op day one.
Yes, it can. It presents suddenly only, Dr. Niklesh, but the duration has to be taken into consideration. Normally, it presents within 6 to 12 hours. It doesn't present later than that. So here, what is the presentation? When did the patient present?
This was second day of LSCS.
So that after 24 hours, it would be unusual if the history is very clear and the documentation is very clear that it occurs after 24 hours. But within 12 hours, and up to 24 hours, if there are signs of hypoxia, hypotension, it is very much compatible with amniotic fluid embolism, and it is sudden in onset. It is severe in nature, and the difference is that in pulmonary embolism there is only RV dysfunction, while in amniotic fluid embolism you have LV dysfunction also, and along with DIC. So these are the ways you make it out. And in amniotic fluid,
she had some oozing from her operated site. And again, that is why the DVT prophylaxis was deferred. Usually they give it around 6 to 8 hours later post-procedurally. But again, it was deferred because they thought that there's a minor ooze and that can get precipitated. So they wanted for it to.
So here it is more relevant to defer it because she's oozing. But in the previous case, it was probably not so prudent to defer it because menstrual flow is not a contraindication to prophylactic anticoagulation. So sometimes we tend to follow more subjective guidelines rather than objective, and we end up in trouble. But sometimes things are difficult also. So I think with that differential, we should go ahead.
One more, Dr. Tapesh, at this point, though it is long shot, but always keep in mind, there is always a possibility of abnormal presentation of peripartum cardiomyopathy. So when we said MI, actually in this setting, very rarely I have seen sudden, arrhythmias coming in for those people who are actually evolving, but usually that would have been a multiparous female, or probably sometimes even a primary who has been having pregnancy-induced hypertension. But very rare incidences of peripartum cardiomyopathy without any preemptive history is known, and usually can present in the first 48 to 72 hours.
She had delivered before, sir, and actually absolutely normal obstetric history, absolutely healthy. So, I mean, again, we were like slightly.
Just like I agree.
No, that is true, but as a general pointer, towards dysfunction, hypertension, like sir has said, one should always think of peripartum cardiomyopathy. And just to summarize, what all can embolize to the lungs? So you can have blood clots, you can have fat, you can have
catheter fragment, small tissues, and tumors.
Tumor, that is what I wanted to highlight. Tumor embolism sometimes can occur, and one should be aware of that. And one more thing is in IV addicts, you have talc, also talc lung disease. So there are 5-6 things which can embolize, and a close mimic of pulmonary embolism is actually air embolism, which sometimes we miss and which is difficult to pick up. So I think we'll move on now, Dr. Niklesh.
For the sake of student, one very peculiar anecdotal thing. Sometimes Ryle's tube feeding, if connected wrongly to an IV fluid, can also embolize. So don't be surprised if some examiner tries to fox you by saying that what will happen if the IV, if the Ryle's tube feeding is actually connected to an IV line. So there is something called as a feeding embolization also, but that's something which I don't think you should even volunteer yourself. Thank you.
Right. So going on to the next thing, again, echo came to our rescue. So I guess everybody can see the loop.
Yeah, if you can see the loop, you want to tell the finding, anything, whatever what you want to say.
Same thing. I mean, RA-RV dysfunction, and again with such a severely unstable patient. So the diagnosis again, I did not have time to shift the patient to CT.
So with this echo, Dr. Niklesh, I think you have nailed it, because if you do this echo, the only thing which is more specific than this is to document clot in pulmonary veins.
Correct, sir.
Which is supposed to be possible by only a good echocardiographer. But this is classical McConnell's, where you can see a good free wall, kind of hypokinesia with preserved, kind of this apical contractility. RVID, LVID ratio is probably 2:1. And there is a reverse Bernheim effect, which is very important. This is the most important pointer based on which you can justify a thrombolysis, even where there is a relative contraindication. Last but not the least, a TR-jet, if you can quantify, that will give you a good idea. A TR-jet which is significant will tell you the diagnosis.
A TR-jet requires some more technical details, but RA-RV dysfunction of this type is very easy to pick on a focus. So we just went ahead, again offered this option to relatives. And again, it becomes difficult to tell relatives of a sudden onset. Once you see a patient, young patient who's arrested, comes to ICU, and then you tell them that, look, this lady probably has a clot. We cannot do a definitive diagnosis until we do a CT, but there is no point and we cannot shift her to CT. So we'll have to take that risk, and we have to understand the bleeding risk and thrombolyze her.
Actually, like Dr. Ansari said earlier, if the patient has a suspected embolism and you get RV dysfunction on echo, for which there is no other reason, and you cannot shift the patient for CTPA, you can go ahead legally with thrombolysis in a life-threatening situation. It is it is accepted. You do not have to document with CTPA, but there should be RV dysfunction, because you cannot have hypotension due to pulmonary embolism and shock or cardiac arrest without RV dysfunction. So that much documentation has to be there with echo. With that, you are legally safe, and as a treating physician, you are safe, provided you also consider other causes of RV dysfunction and correlate with the clinical history and the scenario.
Correct. So we went ahead. She was thrombolized, and return of circulation was eventually achieved. She sort of stabilized her rhythm. The only problem was that she developed ischemic acute tubular necrosis. She did require renal replacement therapy for 2 weeks. Her sensorium gradually improved. She was weaned off the ventilator. Her ATN recovered, and she was shifted to ward with stable hemodynamics by 16th day. And to carry on further, she further improved.
My point to add here, just a point to add here, that these patients who are having such severe pulmonary embolism, weaning can be a little tricky in these patients, and it is one of the major cause of failed weaning. And the subsegmental and segmental PEs, they often have a lot of trouble in during weaning. So, so this patient improved, so that's a great thing. But any patient who is having difficulty in weaning, subsegmental or segmental type of PE should be kept in mind.
Correct.
So other thing I would like to add is that in the duration of CPR in patients who are done in this kind of situation, secondary to MI or secondary to PE is extended. You should not give up CPR before 60 to 90 days, 90 minutes in these patients.
We were able to put in tenecteplase in about 15 to 20 minutes time duration.
Yes, but the duration of
the
CPR
fastest drug that we have. You sort of just push it in, and then you see the effect. Because all the other ones take some time to be given fully in full doses.
Yeah, so, but it is the duration of CPR, your cardiac massage, etc., should not be terminated before 90 minutes. These are guidelines in the cases of MI with thrombosis and cardiac arrest, and pulmonary embolism with cardiac arrest. Normally we stop after 15-20 minutes or half an hour at the most. But here extended CPR, extended cardiac massage is advised because it takes time for your thrombolytic agent to thrombolize the clot and re-establish the perfusion.
We had given them this option, and even she was given an option of VA ECMO in case of we are not able to get the return of spontaneous circulation, as well as if we are not able to, sort of successfully thrombolize her. But she sort of got her circulation back, so we were okay with it.
So, Dr. Ansari, is it the last slide on the case?
There's one more.
So, Dr. Nikhilesh, if I can, there is something I will later on share with you because I thought if I can show, there was one consensus guideline. I remember I was a part of it in 2014 with Dr. Dalal and all the other cardiologists where we discussed about this. So there is a JABI article, which is an Indian consensus PE guideline. I was a part of it, where we specifically made a point. So just to kind of tell all the audience that if you are forced to do a decision like this, you have enough evidence to protect you. Which has been clear that if patient is hemodynamically too unstable to go, and a 2D echo has shown either pathognomonic or much likelihood of a pulmonary embolism based on those 3-4 criteria, you are justified in thrombolizing after risk-benefit analysis after what is called a consensual decision with the family. And I think that's the perfect thing you did, Dr. Nikhilesh. I must congratulate you on that. And you should, as Dr. Tapish said, we should not give up on the CPR. The only worry that I have is if your primary rhythm has become asystole, continuing CPR beyond 30 minutes, even in this kind of a situation, drowning and other things, will also be associated with a poorer neurological outcome. Correct. And that is something which has to be kept in mind. But any, pulseless electrical activity or any other rhythm, you are certainly justified to continue till an asystole happens, or at least 90 minutes, as Dr. Tapesh very clearly said.
Right, sir. So I'll go on to the next slide. So in follow-up, she improved gradually. She required significant amount of blood products. She had significant dose from the operated site, and we attributed it to thrombolytic therapy. And when we went through the literature, it does happen. Yeah. She was mobilized, ambulated. She has remained on anticoagulants for next 6 months, and her further course has been uneventful on follow-up. So this is the last case, actually. So for a change, this is again a male, this is a change from that. But most of what I picked up is from last 6 to 8 months, whatever younger patients we got, is sort of atypical Bs. This has got a 30-year-old male who presented with gradually worsening dyspnea over past 1 week and DVT in left lower limb. He was initially treated elsewhere and referred to us for further management and evaluation. D-dimers were elevated, and he had tachycardia at baseline, though his hemodynamics were stable. Shall I give you the initial part of workup itself, or you would like to discuss on the previous slide only?
No, please.
Okay. So we went ahead. Echo was sort of within normal limits. The only thing was that this guy had elevated PA pressures. He had a lower limb Doppler, which was consistent with left-sided loss of flow till iliac. He had a borderline BP of 100/70 with sinus tachycardia. Oxygen requirement was high. And he went on to require, as high as, he was put on HFNC at 30 liters with 80% FiO2 to sort of maintain oxygen saturations above 92%. CBC was consistent with anemia. Leukocytosis was more than 1 lakh, and he had thrombocytopenia to go along with it. So, any thoughts?
I think this is a very high oxygen requirement, and here, since your echo is normal, it is not consistent with just thromboembolism to the lungs. I think here a very important role is being played by leukostasis in the lungs, because you have a leukocytosis more than 1 lakh, and this is probably some kind of a leukemia we are dealing with, because there is apparent infection. Sometimes you can have a leukemoid reaction where the TLC is high and it reaches 80, 90,000, even 1 lakh, not beyond that. But I don't think there was a infection here. So we have to consider CBC as a part of a malignancy, either acute leukemia, AML or something. And when you have such high counts, they cause pulmonary leukostasis. Sometimes in the brain, they can cause CNS leukostasis. That is, the WBCs, they clog the circulation, microcirculation, and can contribute to hypoxia. The reason why I say that this is contributing to a great extent to the hypoxia is because there is very significant hypoxemia without RV dysfunction. If the embolism was so much that it was causing hypoxia to this extent, then it would lead to hypotension and RV dysfunction also. Because I think the blood pressure is kind of low, normal, but it is normal. It is not hypotension. So that is the way I would look at it. Dr. Ansari sir may like to contribute something to this.
No, I completely agree, Tapesh, that this is very surprising. Can we just go back onto the previous slide once more?
Yes.
Any other?
Yeah.
So he was gradually worsening dyspnea for a week, and there was a proven DVT. Was there any other workup done for this gentleman for the DVT so far?
No, nothing else, sir. Again, this guy was referred to us from a peripheral place, and like up till the point in time he became dyspneic, he was staying happy with some other hospital, some in periphery.
Yeah, so there is a high pre-test probability that this gentleman was having a hypercoagulable state. He doesn't have any immobilization, any injury to the leg, and no trauma. And this is kind of an unprovoked DVT. And that too in a 30-year-old with a consistent leukocytosis. As Dr. Tapesh said, that we are looking at a malignancy associated DVT. There is a clear-cut terminology for that. In fact, DVT can be either malignancy associated or immobilization or surgical associated. These ones usually have very high D dimers. How high was the D dimer?
It was around 2000 something.
Correct. So I think they, when we talk about management, they usually have a paradoxical better response to unfractionated heparin, if I'm not wrong, as compared to low molecular weight heparins. Malignancy associated DVT.
I didn't find any clear-cut evidence on that, ASH and everything, but maybe partly yes, but not a definitive something to say that yes, it is definitely like that. So
fair enough. We can proceed.
Yeah. So this was the findings, and then we
What
go
was
to
the
CT.
platelet levels of this patient? Platelet levels?
This guy's platelet levels were in the range of 80,000, sir.
Okay, because that would be one important thing which, if we are thinking of any heparin or anything else, that the risk of bleeding will be high if the platelets are too low.
Yeah, but actually why we took up these cases was basically because none of these cases are the typical run-of-mill cases. They were slightly different, wherein we faced some therapeutic dilemmas.
Yes.
So this is the loop, sir. I'll try to pause it in between.
Does it look like an aortic dissection?
No, there's no aortic dissection, sir.
That there was some kind of a flap or something. I don't know whether I'm overreading it. The contrast going through the aorta.
Yeah.
There's a semi-lunar crescent kind of a scenario there. I don't know what it is.
Flap is looking like a flap is there.
But definitely the right pulmonary artery is completely occluded, at least one of the segmental branches. There is no saddle thrombus, obviously. And the pulmonary artery definitely is big, but not bigger than the aorta.
Correct.
NPA. Yeah. But you said that there was an elevated PA pressure.
Yeah,
so
there was an elevated PA pressure. It was in the range of it was in the range of 50 to 60.
Again, then that means there was some kind of a subacute process going on. Because to have a PA pressure acutely elevated beyond 40 is really unheard of in a pulmonary embolism scenario. RV cannot accommodate that kind of a pressure. So I think that is something to think about, whether this guy was a smoker, whether he had some pulmonary problem, pulmonary histiocytosis or something, which is also a part of this disease. And as Dr. kind of Tapesh did say, that whether there was a lot of pulmonary leukocytosis contributing to a secondary elevated PA pressure.
So any other thoughts? Because this made my job tough with his hematology.
Yeah, there could be a condition like the patient might be having some chronic issue, and chronic pulmonary embolism like thing would may be there because the patient is having swelling of this left lower limb is there, DVT is there. So this may be having a CT, pH.
Actually,
pressures of around.
When he was referred to us from outside, they did not attach that much importance to his leg swelling. They came to us, this guy came to us primarily because he was becoming dyspneic. He never thought that he had a major problem with his leg swelling. So he was unable to, sort of localize it from when is this leg swelling there.
So, Dr. Nikhilesh, do we have the lung windows showing whether there was any kind of a major, what is called non-consonant, what is called a pulmonary lesion? Was there a pneumonia or something as well to explain
No,
the kind
nothing
of?
was, and there was no pneumonia. There was no pneumonia. Sir. That's what we ended. That's what we were thinking, like with a sort of not too bad an echo, just with some elevated PA pressures, and with so much of oxygen requirement. Are we missing out on something? So the first thought that came to us, whether it was a gradually evolving pneumonia or whether it was a progressive lung disease which is causing it, but it was not fitting in.
So there is a possibility that the small capillaries in the small vessels definitely were having or a catheter or a thrombus which has broken down and gone more distally, causing what is called as a pulmonary, what is called interstitial pulmonary kind of involvement, which is causing so much of what is called reflected high pressure, although the cross-sectional area of pulmonary artery is not really as involved. But I think these are more of distal thrombi, but in a larger bed, causing such kind of a major oxygen impairment.
Yeah.
What was the PA pressure, Dr. Nikhilesh?
50 to 60, sir.
Huh?
It varied between 50 to 60. We did 3 echoes.
So actually, for acute process, that is very unusual. PA pressure generally does not go that high. I think 60 is the highest that has been described in you can get in acute process.
So this guy came to us with dyspnea. It was gradually increasing, and how long that leg swelling was there was something he was not able to, sort of tell us. So,
so you see, the definition of acute would be anything over a period of 1 week. If you have a normal PA pressure and it develops over a week, that would loosely classify as 1 week, and it does not cross more than 60. That has to be borne in mind when we try to look at acute pulmonary hypertension and chronic pulmonary hypertension. And the rise of PA pressure going to systolic more than 40, 45 generally is associated with the TR, because the RV is normal initially. And if there's a chronic process, chronic pulmonary hypertension, there's a right ventricular thickness, and it adapts, and you may not get a TR. So this is interpretation of the PA pressure vis-a-vis the RV and the TR that you get, just to estimate the acuteness and chronicness of the PA pressures.
Correct. Shall I move forward?
Yes, yes.
So when we went ahead, he was diagnosed to have acute promyelocytic leukemia on bone marrow study. This guy was initiated on hydroxyurea with a view to curb leukostasis. He was offered ATRA-based chemotherapy and leukapheresis, but that was refused by the relatives. He was initiated on low molecular weight heparin, still in consultation with a hematologist. And gradually, this guy showed improvement with decrease in PA pressures, leukocytosis, and thrombocytopenia, along with oxygen requirements. He was shifted to wards on day 9 with a requirement of 4 liters of oxygen, stable hemodynamics. But after reaching the ward, this patient was lost on follow-up because they took a discharge against medical advice. So we've covered most of this, and yeah. So this is how the case went. Any thoughts? I think surprisingly, today the time is crossed 6 p.m. I just saw it.
So actually, the fact that it has cleared up so quickly is, I think, indicative more of hydroxyurea working and causing the TLC.
Probably it was more of leukostasis. That's what we thought.
So, and AML, is associated with venous thrombosis. You can get venous thrombosis with thrombocytopenia. You can get it on anticoagulants. You can get it with impaired coagulation profile. So it is not uncommon. Sometimes it's thought that if the patient is having thrombocytopenia or is on anticoagulants or the coagulation profile is impaired, you cannot get your DVT, but you do get it. It is not so unusual. And these patients, if possible, also have to be anticoagulated. Dr. ANSARI, sir, your comments.
No, I completely agree, Ramesh. Absolutely. Malignancy associated, I'm not able to recall. There is a full article which had come about carcinoma associated DVT. and they have a little different, what they call is, they are contrary to, red clots. They are usually whiter clots. And that is why there may be less fibrin specificity required for managing them. And I'm not able to recall. There is a little different kind of anticoagulation efficacy in one of the older articles. And remaining point about raised PA pressure, that was an outlier. If you have an acute DVT process, having a PA pressure above 40 also starts making me a little concerned whether there was some other history which was causing, or there was peripheral pruning happening of the vessels because of some kind of interstitial lung process. And I think hyperleukostasis would have been one of the contributors. Thank you. But it was wonderful cases, Dr. Niklesh. Excellent.
Thank you, sir. Actually,
To add,
we have put all peas in one basket today.
Actually, very nicely managed also. And I think that second patient who actually expired because she was post-operative, she might have been, you gave thrombolysis and you can't really do much about it. She kept on bleeding. Because
Post CPR thrombolysis, I mean, while thrombolysis with an ongoing CPR, from whatever I've read in literature, mortality can be still as high as 60%. So,
yes,
so
that
I
is,
mean, I take it that way that for me it was 50-50. So that is okay. But all young patients, sometimes you wonder, it is something very preventable.
I think we have managed very and wonderful cases. So please go ahead with your presentation, short presentation that you want to make. So to highlight the guidelines and the features.
Basically, just few small points to discuss. Like for pregnancy, I mean, it would be more of use for PGs. That probably the only recommendation is to give low molecular weight heparin and unfractionated heparin. Even in that, low molecular weight heparin is supposed to be much more superior. When they talk in terms of DVT prophylaxis dose, there's very unclear benefit for using a twice daily dosing versus once daily dosing. There were some papers about intermediate dosing, but again, a concept not really well established. When they talk in terms of catheter-directed thrombolysis for stable patients as an elective procedure, that is sort of still held back for pregnant patients or obstetric subsets because there's some risk of radiation exposure. Even though you have got certain guidelines which are sort of like, iffy on whether a significant radiation exposure happens or not, but it is best reserved for patients with a limb-threatening DVT. And again, conversion to IV unfractionated heparin. This is pretty standard, but 12 hours before. There are more guidelines from New Zealand Society that have come in 2021 and ASH, American Society of Hematology, which clearly states that probably it would be better 12 hours before surgery, you sort of switch over to unfractionated heparin, and again 6 to 8 hours after surgery, you can again switch over to low molecular weight heparin. That's what they say. Though, of course, keeping in mind that we do a repeat APTT, which is drawn after 4 hours. Patients who have high risk of recurrent VT, especially those who have had proximal deep vein thrombosis or pulmonary embolism, which was diagnosed 2 to 4 weeks prior to delivery. Postpartum therapy for breastfeeding women who have an indication for anticoagulation. Again, in this, for postpartum, you can go ahead and use warfarin and fondaparinux as well as dalaproid as safe options. And coming to the last slide, we are not always successful in saving lives. It is extremely common to have PE nowadays. Prophylaxis can be invaluable. And believe me, you can have very variable presentations requiring you to take certain decisions, which may be very life-altering, which may be very, very difficult to make and take both for the consultants as well as relatives alike. So that is all. Any further comments, sir?
If I can just make a note, Dr. Niklesh, I was just going through that. It is called cancer-associated thrombosis, CAT. There's a very nice article. And if I can, I don't know whether I can share something right now.
You can share the screen, sir. You can
share your
stop
screen,
your
sir.
share screen, Niklesh.
I'll unshare mine. Just a minute.
Let's stop the share screen.
So screen and here. So is my screen visible to all?
Yes, sir. Yes,
it is coming on a short, in a very narrow view, but we can see it. It's all right.
Yeah. So this is called CAT, Cancer Associated Thrombosis Therapy. Very nice article. And this is what I was trying to say. A very comprehensive article where it says that cancer associated thrombosis can actually present in different manner. And the major risk, the interesting for about students is that the rates of cancer associated thrombosis can be impacted by a lot of cancer related risk factors. The cancer site of cancer, and then staging of cancer, and histology. And the mechanism is very interesting just for the PG students who are here, that it can be because of microparticles, cytokines, neutrophil extracellular traps, and very interesting angiogenesis inhibitors. So I think people should find time to read about this mechanism, and a very, very wonderful article, I think. And maybe in the future, Dr. Tapesh, we can make a small kind of compendium of these articles which the presenters can share with all our listeners maybe later on.
Yes,
maybe put it across as a link or something wherein people can have access to these articles.
And the interesting part which I was talking about, I'll just read about the treatment if we have 2-3 minutes, just to tell you that.
Please, all the time.
Yeah, so I'll come to that. And hypoxia, this was the reason why hypoxia was so aggressive. They have a highly hypoxic microenvironment. So probably that is the reason why you had such aggressive hypoxemia, Dr. Niklesh.
Okay,
And and lastly, the therapy part, I just thought I'll just quickly. So for here, they said that combination of cancer-related, treatment-related, and patient-related factor, the pathophysiology of cancer is multifactorial and have significant, morbidity and mortalities over here. Therapy-wise, there is an exhaustive review on this topic available, which we should read because we are seeing a lot of onco cases nowadays in every hospital. So it's important for the physicians to know. And as rightly asked, that whether there was associated thrombocytopenia, that will be important. There was one guidance, the chest guidelines for VT in cancer. The chest guideline and expert panel report suggests usage of LMWH over vitamin K antagonists and LMWH over direct oral anticoagulants. So this is something which may be probably important. I think I just wanted to point towards this, that our students should go through this and read out cancer-associated thrombosis as a separate entity. Thank you. Thank you for this. And I think I should stop saying. Over to you, Dr. Tapesh. Thank you, Dr. Niklesh. Thank you.
Thank you, sir. You're wonderful as always.
Just 2 points to add to this cancer-associated DVT. The first thing is that I also read some articles about it, and they say that the chemo port or the central lines are used for therapy. These are major reasons why the incidence of whole limb DVT is high in cancer-associated patients. Okay, and this remains a very important part of analyzing a patient for the not only for the treatment part of view, for the duration of therapy as well. So if a patient who is having central line and he's having in the same limb, the upper limb DVT is there, then the duration of therapy remains 3 months and you have to remove the central line. And if the patient is not having related to the central line, then they say that you have to give at least for 6 months, and you have to also consider the status of the cancer at that point. So if the cancer is continuing to be active, then you have to give at least for 6 months. If the cancer has gone into remission, then you can think of stopping after 6 months. Okay. And the drug of choice remains the LMWH. And if the patient is stable, can convert into direct oral anticoagulants, and adoxaban is probably the better the DOACs. And third, they also mention is that you have cancer, you have to see the risk of bleeding. Like a patient is having gastrointestinal tumors, the risk of bleeding is too much, and you have to be very careful in giving the dosages of anticoagulants, and sometimes you have to go for a lesser doses in the patients who have had a high risk of bleeding.
No, very pertinent points, Dr. Kishore. Very pertinent points. I think UE DVT, upper extremity DVT, is very poorly recognized. But two areas: one, malignancy, chemoport induced this or PIC lines insertions, and number two, the permacath that most of our chronic
Yeah.
kidney disease patients need. So these are the two subsets where I think upper extremity DVT must be kept in mind. Any unexplained hand swelling or persistent thrombosis in the hand, which usually people call it or associated superficial thrombophlebitis, must be always dig deeper. And UE DVT, in our own study of 100 DVT patients, we found that 5% of the patients were upper extremity DVT, and most of them actually were having DVT when they admitted in the hospital, which was undetected. They didn't come for that. They came for sepsis and other thing, and we picked up UE DVT just by being more vigilant and doing more duplex scans. So, thank you for bringing that point.
So, Dr. Siddharth, you have anything to say? Dr. Siddharth? So, Dr. Ansari sir, you would like to comment on what is the treatment strategy if there is a contraindication to thrombolysis? Sometimes, like post-surgical patient who gets a PE but needs to be thrombolized and you have time and you can do other things. So, what kind of options do you have here? One of the indication, one of the strict contraindications is bleeding coagulopathy or a post-operative period. Up to 2 weeks after surgery or LSCS, it is not advocated to do thrombolysis if possible, unless the patient is resting. Like here, we have these two cases where they are arrested.
So I think if I can show this slide, is it visible now?
Yes, we'll have to enlarge it, sir. Actually, reading it is.
Yeah. I don't know. So just to kind of tell that point, when you said that when CT is immediately available and patient stable to shift, we can go through the whole gamut of investigations. If it is not available or the patient is not stable to shift, the echo. This was just kind of to show that you treat for PE if the echo is showing signs of pulmonary embolism. That was one part. Coming back to the other issues of contraindication and what other things can be done. I feel, Dr. Tapesh, multidisciplinary team. In fact, there is some suggestion that PERT, pulmonary embolism response team, should be there in hospital. Now, I know it is very difficult for all of us to have this in our institutions, but if you have more than 500 bedded institution that you work at or a government institution, it's worthwhile having a PERT team where multiple discipline, intervention radiologist, cardiologist, pulmonologist, intensivist need to really, along with the primary physicians, need to really take a joint call whether the benefit of doing thrombolysis, anticoagulation, or going on for alternative thrombolytic agents. Sometimes we have used bivalirudine and even like thrombocytopenia, associated thrombocytopenia. You have thrombosis. What to do in those situations? You need to have alternative agents. But in general, the safest bet with a good interventional cardiologist or radiologist would be to go for catheter-directed thrombosuction and maybe limited thrombolysis, which is called as a Stellis device, which is mechanical agitator thrombosuction. And this is something which you need to invest in, and your cardiologist or interventional guy should be on the same page with you.
Yeah. So I think that is very important to realize that if there is contraindication to thrombolysis, there are alternative treatments. Amongst them is the conventional pulmonary thrombectomy. But like sir is talking about now is what is coming up, catheter-directed removal of the clot burden and catheter-related thrombolysis also, where you give in a smaller dose of thrombolytic agent. So catheter-directed stuff is also coming in, and depending on your center, it is being used. And the other is the conventional pulmonary thrombectomy. Because if there are contraindications to thrombolysis, you may go ahead with thrombolysis, but at the end the outcome may not be good because you may thrombolize the clot, but you may end up with the contraindications on the other side. So I think those are some of the things we want to highlight. Anything else, Dr. Kishore, you want to talk about? What kind of thrombolytic agents you will use, or what is advised? Streptokinase and altiplase or tenecteplase?
Sir, so in our settings, we commonly use altiplase. This is the most commonly used. The only thing which I want to add here, apart from all these things which we have discussed, is the role of IVC filter. Okay, so this is another important thing. And in patients who are having a risk of bleeding and the patient is having DVT, then and you cannot anticoagulate those patients, then you can put an IVC filter, and so that the progression of pulmonary embolism is not there, and the risk of bleeding from anticoagulation is also not there. So the retrievable IVC filters are very commonly placed, and I've seen at least 7-8 patients where we have put retrievable IVC filters because of various reasons. And in patients who are having contraindications, it works beautiful.
So, Dr. Niklesh, any final comments from you and Dr. Ansari before we close it?
I will just say, I mean, IVC filters, if I'm correct now, most of the guidelines have gone over them. I mean, in the sense that they've stopped using them, even for, obstetric subsets, LSCS, like we discussed. There's a lot of data on using IVC filters, which they then tried initially using infrarenally, and they were not very happy with it. The outcomes were not really good. Then they advocated suprarenally in some patients. But very, the data is very sketchy, of course, because of the subsets that are involved here. And other thing is that despite that, they had to give anticoagulation. So it doesn't really solve that problem. So you can get thrombi distal to it. So anyway, the thrombi are happening after that. So you need a second procedure or a second step thing to, sort of counter it. I mean, this can be discussed further. I would like to know everybody else's thoughts on this.
No, I agree. There is a lot of equanimity on this. IVC filter, which were go-to places maybe a decade back, definitely went into disrepute because of their non-retrievability and the damage that they can do and becoming a nidus itself. But what Dr. Kishore pointed out is that the current, kind of what is called collapsible as well as retrievable IVC filters have again gained some renewed interest in that. But I would say that the clear-cut possibility of using that would be for a condition where you would not be able to anticoagulate for a significant duration. This is very important. So just because 48 hours you can't, kind of anticoagulate, probably putting an IVC filter is not going to prevent any kind of major advantage to you. Probably you need to go through lower intensity anticoagulation in these patients or finding out the cause for preventing the bleeding. But yes, in certain situations like severe pelvic fracture associated with retroperitoneal hematoma. Now that is one condition where this person is going to be lying down in the bed, high likelihood of DVT, and you are unable to, give them this. This is one subset where a retrievable IVC filter would be really welcome. Number two, malignancy associated severe thrombocytopenias. But again, in general, in those patients, putting an IVC filter itself sometimes becomes nidus. So yes, when you push to the wall, you must consider it. And you need a more expert people. Though they are retrievable, I have heard about, damages to the IVC, even with retrievable filter, because those wings, they are like spider webs, can sometimes go through and through the struts. They can go through the vessel wall. And especially in a diseased IVC, there could be a problem. So individual expertise has to be kept in mind. It has to be kept as a last resort, where you cannot substantially anticoagulation for a duration. And still with an IVC filter, earliest moment to initiate anticoagulation, you have to start.
Yeah, agree, sir.
The classical indications for IVC filter are two. One is there when you cannot give DVT prophylaxis, that is one. There are many situations and one has to judge clinically. And these are the broad guidelines. Second is when the patient has embolism despite anticoagulation and even not be able to tolerate thromboembolism, then also you put a filter. So these are two of the broad indications wherein you have to work clinically, like Sir has said, judge clinically and then put the IVC filter. Otherwise, the duration of IVC filter generally these days is 3 months and they are retrievable, and after 3 months you remove them. And sometimes the process of putting the IVC filter is itself a problem because these patients are having a tendency to bleed. One of the contraindications for giving DVT prophylaxis is if there's a tendency to bleed, and that would again make it difficult to put in an IVC filter. So IVC filters have become a rarity, but yes, they are indicated in a few situations. Another interesting point I would like to bring about is when to ambulate a patient with DVT, and should we ambulate? So the answer to this is yes, we can ambulate, and once you have started anticoagulation and achieved your goal of anticoagulation, that is in a couple of days, you can ambulate these patients. There is no contraindication to ambulating a patient with DVT once you have started and given adequate doses of your anticoagulation. The other thing is, should we give DVT prophylaxis to patients we commonly discharge from the ICU who are bedridden? What is the indication to give anticoagulation to such patients? You know, they are bedridden, they go home, like hypoxic encephalopathy or other neuro patients or other, patients with a lot of comorbidities who are bedridden. So there is no indication to give anticoagulation to these patients, despite the fact they remain bedridden at home. So trials have clearly shown the outcome is not improved, and that is because they have so many other comorbidities that they die or expire from these comorbidities. So there is no indication to give anticoagulation to patients who are discharging from the ICU are going to be bedridden. So just a couple of practical tips and practical points I wanted to highlight. So anything else from the house? Any comments?
So I think there is a very nice study which had shown that continuing anticoagulation for all high-risk patients from the ICU didn't actually had a great impact on the outcome. So that's right, Dr. Tavesh. But at the same time, orthopedic, spine, pelvic fracture, trauma, in these patients, benefits have been shown up to 30 days. So the most important, the recommendation by I think the Chest Society has been that for at least 14 days after a knee replacement and for 35 days after a hip replacement and probably up to 60 to 90 days for those people with spine surgery, immobility and established DVTs. So those duration and timelines should be should be very well defined.
Absolutely, sir. So anticoagulation is very important, especially in these high-risk patients. And we have seen embolism occurring here in such patients where it was delayed. And this is the vulnerable period, actually. The first 24 to 48 hours is really the critical period where the arteries have been, disrupted and they are prone to thrombosis. So I think if there's nothing further to add, should we close it, Dr. Ansari, sir, and Dr. Niklesh, sir?
Yes, sir,
I think
absolutely.
we did.
Okay, then.
Wonderful discussion.
So thank you, God, and thank you, everybody, for joining in. Thank the audience. Thank Niklesh sir, Ansari sir, Kishore Mangal sir, and SIDDARTH Goswami. Thank the audience. Thanks Cipla Pharmaceuticals for providing the thank you very much.
Thank you, sir.
Thank you,
Thank you, everyone.
Thank you, everyone.
Thank you, sir. Thank you, sir. Thank you, everyone.